You've probably heard of the ACL before. If you watch any sports games, if you watch soccer or football, you've heard of a team member breaking their ACL here or tearing their ACL there, and you're wondering what exactly is the ACL. So the ACL is the anterior cruciate ligament. It's one of the most important ligaments in the joint. So you're probably watching your child play a big game at school, and suddenly they fall into the ground and they're clutching their knee and they just can't run anymore. Yeah, and you think there's something that's probably broken or dislocated. And today I'm going to talk about ACL injuries. My name is Judith Nasazi. I'm a pediatric orthopedic surgeon, and I understand the fear, the confusion, and the overwhelming desire to do what's best for your child. Today I'm going to take you step by step in what we can do about protecting and taking care of ACL injuries. So we're going to cut through the medical jargon and skip the scare tactics and just give you the straightforward facts that you need to understand to help your young athlete prosper. So consider this your roadmap through the fields, like the impossible journey. All right. So what exactly happens? So let's talk about what actually is going on inside your child's knee. So think of your child's knee as a complex, perfectly engineered machine that is held together by a network of strong fibrous ropes. And inside every knee, there are 4 major ligaments. You can call them knee strings or something. So these connect the thigh to the femur bone. Among these is the anterior cruciate ligament, or the ACL in short. It's often the smallest, and yet it arguably does the biggest job. And what job is that? So it prevents the shin bone from sliding out too far on the front of the thigh bone, especially when your child twists, jumps, or lands. It's what keeps the knee stable when they make those lightning fast cuts on the field. So when an ACL tear happens, it's usually because an incredible force has simply outmuscle this tiny but mighty rope. So picture a sudden stop, like they're running really fast and they stop, or they quickly pivot, or a sharp cut when they're running really fast. When your knee joint is forced into unnatural positions of hyperextension beyond the limits the ACL can snap, the athlete often describes this as like the knee opens up and then it just they hear a pop followed by like immediately swelling up and massive pain. So within just a few seconds to minutes, the knee literally fills up with blood, and they'll feel it very wobbly, and walking may be very uncomfortable and pain. It's a common misconception that ACL tears are just for boys, but that is not true. Both boys and girls get ACL tears. But there's something crucial about understanding the ACL tears in girls. So girls are at a significantly higher risk of getting these tears, and we'll explain that shortly. So why are they more complex in girls? So a complex mixture of factors like anatomical differences and hormonal changes attribute to why girls are at a higher risk of getting those tears. So girls sometimes rely more on their quadriceps than the hamstrings, which can put extra stress on the ACL and putting it at risk of tearing. What kind of sports put children at risk of getting this injury? So any activity that really involves sudden cutting or pivoting, jumping, or even rapid changes in direction puts them at risk of this injury. Think of things like soccer, basketball, lacrosse, football, really many, skiing, competitive cheerleading. So these are all sports that consistently are top of the list to leading to injury. So if your child goes down, does hear a pop, and then suddenly their knee swells up, they can't bear weight, that means no more play. Immediately you need to apply some ice, give it some gentle compression, give them some crutches, and then take them off to the hospital as soon as possible. Every minute is important in this case because they're in excruciating pain, they're scared, and then they're unable to walk on that leg. How do we diagnose ACL injuries? So when you see your doctor, they will do a quick clinical examination. The history is very important. So once you've given them details of what happened, they've done a clinical examination, then they can be able to probably think it's probably ACL or something different. We don't routinely do x-rays for ACL injuries. Sometimes they can be done to try and rule out any bony injuries, but they won't confirm an ACL injury. The gold standard investigations and MRI scan. So the MRI scan is done. It can help us show the discontinuity in the strands of the ACL, or also help us pinpoint any associated injuries inside the child joint. Sometimes they get injuries to things like the meniscus, but that's a discussion for another time as well. So the unique thing about injuries in these children is that they have growth plates as well. So we have a video on growth plates as well, and you can review that later to understand what growth plates really are. So when your child has an ACL injury, you're going to discuss with the doctor the options that are best to manage this this injury. We need to identify this early and try to keep the child off that joint, because I mean, intuitively, children are very playful and they'll just want to go back and play as soon as the pain goes away. But understanding that something has happened inside the joint that needs to be taken care of is something that has to be discussed with the child, so that they can understand why certain interventions have to be done to try and protect this knee. All right. So this isn't a small injury, and it's not like injuries in adults. Because of the presence of the growth plate, it just changes the dynamic of how it's going to be managed and the recovery, what the recovery is like. You need to see a pediatric orthopedic surgeon who is going to discuss with you the different options of management. What does management entail? So there is the first phase of management, and that typically involves physiotherapy to try and, well, take care of the swelling, but also regain the range of motion of the knee. And this is done until the child is able to get near to normal range of motion of the knee, like the other uninjured side. After that, then surgery is done. The surgery is to try and reconstruct or give your child a new ligament. And the new ligament is made for them from they get a graft from one of the tendons near the knee, typically the hamstring or the quadriceps ligaments, and these are placed inside the child's knee to reconstruct the torn ligament or the torn ACL. You might wonder why I talked about just surgery. Isn't there room for just leaving this alone or managing it without surgery? Well, because when your child injures their ACL, they're going to have an unstable knee. They're going to keep buckling when they walk, where their knee is going to keep buckling, and that particularly injures the structures inside the knee. The most important structure here is the cartilage that covers the joint. So repeated damage to the cartilage leads to irreversible damage to the cartilage. So when you damage your cartilage, you expose the bone that the cartilage covers, and this puts you at risk of arthritis. Arthritis is a very painful event joint. We want to prevent that. And so the goal of fixing the ACL is to try and protect the knee joint, or protect the joint from, constantly rubbing away or injuring that cartilage and leading to early onset of arthritis in the knee. So once the surgery is done, your doctor will probably have you in the hospital either for a day or so, based on how you're doing, and they'll put you in a brace. The first 2 weeks typically involve you being in a brace and preventing motion of the knee to try and get the wounds to heal, the swelling to go down. But then after that, you'll start a gradual process of physiotherapy until your knee fully recovers, until the graft fully recovers. Like I mentioned, treatment for children is very different from that of adults. Based on how old the child is, the graft could be passed within the growth plate or behind the growth plate. The reason this is done is to prevent injury to the growth plate. The growth plates are the machines inside the child's bones that allow them to grow taller. So if an event happens to the growth plate that affects the growth plate, really, it will affect the growth of that bone, and you don't want that to happen because it can lead to deformity, or it can just completely stop the growth of that bone. So it's important to know, these things so that it's done correctly. The surgery isn't really rushed, but it's important to know that they need surgery. So it's typically scheduled for weeks to months after the injury. The delay is really intentional and it's beneficial. It allows the initial swelling to go down and crucially gives the child time to regain their range of motion. And the pre-surgical rehab is very significant because it lowers the risk of post-operative stiffness and it helps preserve the delicate cartilage within the joint. So it's about setting your child up for the best outcome, all right? On the day of the surgery, what really happens? So naturally, you're probably very nervous about this, but let's demystify what actually happens. The procedure is called arthroscopy, which sounds complex, but essentially just means looking inside the joint. It's a minimally invasive surgery, and the surgeon will use little cameras to look inside your joint to see what really is going on and fix any problems that are going on. It's usually just a few millimeters of incisions that are made to access the knee joint, and then the cameras are placed, and we can directly look inside the joint and see what is going on. So the torn remnants of the ligament will be cleaned away; they will be removed, and then with maximum precision they'll drill into the bones and put for you a graft of the ligament to try and reconstruct this ligament so your child can have a new ligament in their joint and hold the knee intact. The entire process is remarkably efficient, usually taking about 2 to 3 hours, and it's almost performed on outpatient basis. So this means that the child comes in that day and goes home the same day. Based on how they do post-operative, sometimes they sleep over to just monitor their pain and check for swelling and all those kinds of things. So they'll also leave with a hinged knee brace on, and it just protects. It's an outer shell that really protects the knee and prevents them from moving the joint prematurely. The pain is natural and it's just part of recovery, but it typically peaks in like about day 3 or so. So don't be afraid to use the tools that the medical team avails to you, things like icing machines, effective painkillers, and sometimes they give you some small frequent doses of narcotics trying to take care of this pain and just keep the child comfortable. The goal really isn't zero pain, but manageable pain. Then at about the 2 weeks mark, your child is typically more comfortable and the pain medication has been weaned off of them. Around this time, then they'll go back in and then we'll have a look at the wounds, see how they're doing, and then we'll start the range of motion of the knee. This is when the real work starts. And this will go on until nearly 9 months to a year to try and restore that range of motion. And still, every surgeon has a tailored protocol that they use for different patients. But what we typically follow is that we'll have range of motion going on until 3 months, then further on until 6 months. Then you'll be allowed to maybe run in the straight line at the 6th mark. And then beyond that, you might be allowed to get into drills, but no pivoting sports. And this is all in an attempt to try and protect the graft to prevent it from breaking, to prevent it from getting torn. So at the 9th month is when we start to maybe slowly start allowing the child to go back to some physics, to some games, okay? But they still need to carry on with a rehabilitation by the physiotherapy specialist. So every day is important. Every day you're going to be learning something. Every day you're going to continue strengthening your muscles and improving your range of motion. But there's some things to note. So get the knee straight first. Preventing stiffness and regaining full extension is very important. Get the quadriceps firing. The quadriceps muscles waste away really quickly and they tend to fall asleep after the surgery. So waking them up is crucial for stability. The third thing is that you need to stop the thigh from shrinking. So muscle atrophy happens really fast, and we want to minimize this. So early sessions might seem deceptively simple, like ankle pumps, gentle heel slides, the light quad sets. But these exercises are building blocks, and they're very essential for restoring the basic function. So as a child progresses, they'll graduate from stationary bikes at about 6 weeks, and that is a very big win. They will go on to light jogging. They might begin to, at about the 12th week mark, they might do we might introduce some bigger movements, okay? So this rehab isn't just about strengthening muscle, it's also about retraining the brain. The brain needs to relearn how to coordinate movements, especially landing patterns, improve balance and agility. Neuromuscular control is also very important, and that's why jumping, landing, and all these drills are incorporated into the rehabilitation. So they do teach the body to move efficiently, to move safely, and also in an attempt to try and protect the new ACL that has been created. Some of the critical points that I need to touch on before we go is return to sports is not a calendar, it's not calendar based. So there's a criteria that is present. Your child must pass a series of objective tests to earn the green light, and these typically include things like quadriceps strength. So their operated leg must be at least 90% as strong as the uninjured side. There's a hop test. They need to be at least 100% symmetrical in hopping on both sides. This need for psychological readiness. So a score above 60 of a validated questionnaire must be fulfilled to get them confident and physically ready for this. So an average timeline for safe return is about 9 months. So I can't stress this enough. Rushing back at 6 months or earlier triples the risk of getting a retear, and that's the heartbreaking statistic. And that's why patience is your most valuable asset during this period. Along the journey, celebrate every small win. The fast full revolution on a stationary bike is a big win. The fast careful jog is a big win. The first time they can practice, with the team, even though they're on the sidelines, is a big win. So all these milestones need to be celebrated with the child. The mountain is steep, but it's conquerable, and one confident step at a time, they can get there. How do we prevent a second tear? So you've made it through the surgery, you've conquered the rehabilitation mountain, and your child is back to the field. So congratulations. But our work isn't over. One of the most sobering statistics is that pediatric sports medicine is that there's a high risk of re-injuring the ACL or just tearing the ACL after reconstruction. And here's another twist. It often occurs on the opposite side, which hasn't even had surgery, highlighting the systemic vulnerabilities in these children. So this isn't just bad luck, it's just a point of factors, and we can address this. So the most effective thing to fix is to prevent the second tear is neuromuscular training. So we're talking about 2 dedicated sessions per week, ideally integrated into the regular training as a separate program. This training isn't just about strength, it's about teaching the body and the brain how to move safely and efficiently. So a core component of this is focusing on the proper mechanics. So when maybe squatting or bending, try to get the knees over the toes. Ensure the knees track properly over the feet, not just caving outwards. The hips should be back and engage the glutes and the hamstrings, which are all very powerful shock absorbers. Keep your chest up when you're doing all these things. Maintaining a good posture and balance prevent the body from collapsing forward. So we need to prevent the injuries. We need to prevent them from getting a second surgery, and we need to make sure they're actually enjoying all this as they go about it. Okay. If you have any questions, don't forget to leave them in the comments below. I engage with the comments every week, and if you want me to talk about any other topics pertaining to injuries in children and how we can fix them, just let me know and we can make videos on this. So I hope you found this video helpful, and until next time, keep it on little growing bones.